Next is about siravyadha vidim shariram vyakhyasyaamah yathovacha bhagavan dhanvantrihi. बाल स्थविर रूक्ष क्षतक्षीण भीरु परिश्रांत मद्यपा अध्वस्त्रीकर्षित वमित विरिक्त आस्थापित अनुवासित जागरित क्लीब कृशगर्भिणीनां कासश्वासशोष प्रवृद्धज्वर आक्षेपक पक्षाघात उपवास पिपासा मूर्छा प्रपीडितानां च शिरां न विद्येत याश्च अव्यथ्याः व्यथ्याश्च अदृष्टाः दृष्टाश्च अयन्त्रिताः यन्त्रिताश्च अनुक्तिताः इति. Now, for the venesection, that bloodletting by the venipuncture or venesection, the indications are, the contraindications are very young age, very old age, and those who are poorly nourished, and those who are afraid of the whole procedure, or those who have strained a lot, and alcoholics, or those who have are exerted by maybe sexual activity or maybe walking or after Vaman and Virechana and after Asthapana or Anuvasana. The Raktamokshana is contraindicated. And Jagarita, who have not slept well, and those who have impotency or even pregnancy, or the diseases like cough, breathlessness, or emaciation, or jvara, fever, or convulsions, or paralysis-like conditions, or those who have not taken food, or those who are feeling thirsty, or who are unconscious. In these conditions, the siravyadha should not be done. At the same time, avyadhya siras, which are described in the previous chapter, they also should not be punctured. And those vidhya, those we are indicated for puncturing, also if they are not directly visible, they are not to be punctured. And those, even after making them visible, they should be properly tied, or tourniquet has to be placed so that the bleeding can be controlled. And if the tourniquet cannot be placed, if without tourniquet you are not supposed to do the bloodletting, and even after tying the tourniquet, they should not, they should become raised, or they should become very prominent where you can easily puncture. If they have not become prominent, then too it should be avoided. So it depends upon the contraindications for the siravyadha, depends upon the physical condition of the person, as well as the status of the vessel which you are going to puncture, whether it can be made prominent or not. Now, Shonsa avaseka sadhyashta ye vikaraha pragabhitaha teshu cha apakveshu anyeshu cha anukteshu yatha abhyasam yatha nyayam cha siram vidyeta. Very important statement. The diseases where the Raktamokshana can be benefited, they are already previously mentioned in the Sutrasana, and the same shloka, Tugdoshaha Grantha Shopaha Rogaha Shonitajastraye Raktamokshana Shilana Nabhavanti Kadachana. The diseases of the skin, Granthi, Shopa, or Raktaja these are the indications for the Raktamokshana. But there again, Apakveshu, very important. It's not that the siravyadha is done in every patient who comes to you, only in those conditions where they have come in the early stage, where there is a apakvavastha, siravyadha is indicated. Once it has reached the apakvavastha, siravyadha is not really indicated. The anukteshu yathabhyasam yathanyayam cha siram vidyeta. And if at all based upon your experience or based upon some logical conclusions, if you feel that siravyadha is indicated, that can be done. प्रतिषिद्धानामपि च विश्व उपसर्गे आट्येके च सिराव्यधनम् अप्रतिषिद्धम्. If there is an emergency, or if there is a real contamination with the poison, and your purpose of bloodletting is to remove the poison, then even in those conditions where otherwise there is a contraindication, it is still indicated because it's an emergency and there is a possibility of poisonous contamination, and the poisonous contamination can be removed by the siravyadha. तत्र प्रोसीजर would be स्निग्धस्विन्नम् आतुरं यथादोषप्रत्यनीकं द्रवप्रायम् अन्नं भुक्तवन्तं यवागुं पीतवन्तं च यथाकालम् उपस्थाप्य आसीनं स्थितं वा प्राणान् अबाधमानः वस्त्रपट्टचर्म अन्तर्वल्कललतानाम् अन्यतमेन यन्त्रयित्वा नाटिगाढं नाटिशिथिलं शरीरप्रदेशम् आसाद्य प्राप्तं शस्त्रम् आदाय शिरां विध्येत. For the siravyadha, the procedure is before the siravyadha, patient has to be given snehana and swedana, as in any case of the shodhana procedure, and the patient has to be given a liquid food before that, or yabagu or any of that liquid food which has to be given before the procedure, and the patient has to sit comfortably, either sitting or standing, depending upon the position in which the siravyadha has to be done. And you have to have a tourniquet, and tourniquet in Sushruta spirit could be based upon the material could be vastra, patta, charma, antarvalkala, lasana, manyasamena. It could be cloth, or it could be thick cloth, or maybe leather piece, or barks of the tree, or creepers, any of that, depending upon the availability and convenience. A tunica has to be placed, and the tunica has to be placed in such a way that it's not too tight or too loose as such, and at the proper place of the body, so that the vessels would be prominent. Then siravyadha should not be done in extremely cold season, naimatishite, extremely hot season, natyushne, napravate, when there is a very fast breeze as such. Nacha abhrite, in cloudy weather, siranam yadhanam karyam, it should not be done. The siravyadha should not be done. And aroge vakadachana, in a healthy person, occasionally, is not that healthy person is contraindicated, but aroge in those who do not have a disease, siravyadha is not a health promoting issue in general. So that's the important issue. The issue controversy is in the previous shloka, the Sutrasan shloka, the meaning would be Tagdoshaha Granteshopa Rogaha Shovitajaste Raktamokshana Shila Namna Bhavantika Datana. Raktamokshana, those who have a habit of doing the Raktamokshana, the diseases would not occur. That's the real meaning. But in the next, in the Sharirasthana, Sushruta has mentioned Aroge Vakadachana. In the Arogi persons, it's not a regular practice. Unlike other shodhanas, Vamana and Virechana, which are done seasonally, Raktamokshana is not suggested as a seasonal, regular habit as such. Anyway, that's the matter of controversy. The issue is now in the present day situation, there are some people, or there is a logic like Raktamokshana also has to be done regularly and so on. I'll come to that part at the end of this session, the issues related to that. Then, tatra vedyasiram purusham pratya adityamkham aratni matra uchhite upaveshya asade sapnoha akunchitayoho nimeshya kurpare sandidvayasya vari hastau antargudha angusta kridam mushtim anyayoh stapayitva yantrana shatakam griva mushtyoh upari parikshipya anyena purushena paschatsyena vamahastena uttanena shatakantagvayam grahitva tato buryat दक्षिणहस्तेन शिरोत्थापनार्थं नाट्य आयतशिथिलं यन्त्रम् आवेष्टयेति वस्त्रक्षालनार्थं च यन्त्रं पृष्ठमध्ये पीडयेत् कर्मपुरुषं वायुपूर्णमुखं स्थापयेत् एषः उत्तमाङ्गगतानाम् अन्तर्मुखवर्जानां शिराणां व्यधने यन्त्रणविधिः. Now the procedure of doing the bloodletting in case of uttamangagatanam, in the conditions of siravyadha, in the upper part of the body, in the head and neck area, the procedure is the person has to sit in a comfortable position in a knee-high seat, and an assistant has to hold the patient in such a way that the arm is kept flexed and the other arm is also kept flexed with a closed fist, and then you have to tie a tourniquet above the shoulder, and the other person, the person who has to remove the blood, has to puncture the vessel above the neck at the proper position. And during this procedure, the patient has to keep the mouth bloated with the air. That's how the procedure is done. Now, the interesting issue is it's that Raktamokshana or bloodletting is not only in the Indian or Ayurvedic system. Every medical system throughout the world in the olden days had that kind of a protocol. In the Western system also, bloodletting was considered to be one of the most important method of treating. I will come to that part. At the end of this, I will come to a bit detail about the history of that bloodletting in the Western science also. But the interesting issue is now it has become totally obsolete in the present day situation, that bloodletting as a therapeutic procedure is not practiced except in a few conditions, and the whole procedure is now categorized as a procedure of torturing, medieval torture. Now this image which I have corrected is from Museum of Medieval Torture, which is a biphasic museum, like where you have a internet-based museum as well as a physical museum map. And in the internet you get these images. So the important is this image is exactly the replication of the description of what Sushruta has said. It has the same description, but this procedure now is included as a procedure of medieval torture. It's not considered as a therapeutic procedure, it's categorized as a procedure of medieval torture. That's the important, interesting issue. And a bit more about this controversy and issue I will discuss at the end of this chapter as such. Then if at all the siravyadha has to be done in the lower limb, padamvidya sirasya, padam samesthane sustitam stapayitva, anyam padam ishat sankuchitam uchchaih krutva, Vedyasiram padam jansande hadha shatakena abestya, hastabhyam prapedya, gulpam Vedya pradeshasya upari chaturangale plotadinam anyatamena buddha va padasiram vichyeta. To have the bloodletting in the foot, you have to keep the leg which has to be punctured in a dependent area. The other leg has to be kept flexed and the patient is in a sitting posture. So one leg will be kept dependent. And then a tunica has to be tied just below the knee joint. And then at the level which you want, like either ankle or maybe wherever it's needed, the bloodletting has to be done. And the area of bloodletting has to be covered with a gauze or maybe a pad as such. Similarly, atha uparishthad hastau guda angushtakritam stihi samyag asane sthapayitva sukhopavistasya purva yantram badhva hastasiram vichyeta. Of course, this is a very common procedure in the routine practice, because most of the times in the routine clinical procedure, whenever there is a need for collection of the blood, even in the laboratory, most preferable area is the cubital vein, and the procedure of making that cubital vein prominent is tie a tourniquet at the forearm and then make the vessel prominent, puncture. Now that's exactly the thing, like you will have to put a Sushruta as mentioned, the patient has to kept in a comfortable position, and the blood vessel has to be the puncture. Of course, this is also an image from the medieval torture museum. Grudasya Vishwachyoho Sankuchya Janakur Parasya. In Grudasya and Vishwachi, the patient has to kept in a squatting position, and in the shown over the buttocks, the bloodletting has to be done. Now, practically, whether such a procedure is done or not, I don't know. I have not done that procedure, so I am not able to give more information about that part. Then Shroni Pristas Kandeshu Unnamita Pristasya Avak Shiraskasya Upavishtasya Vispurjita Pristasya Vichyeta. If at all the bloodletting has been over the back, then in that condition the patient has to keep in a slightly head and lower position, and the back has to be kept raised. So he has to get kept in a supine position, and the back has to be kept raised, head end has to be lowered, and the muscles of the back have to be more prominent. At that level, the puncture has to be done. Udara Gurasoho Prasarita Guraskasya Unnamita Shiraskasya Vispurjita Dehasya. The Udara, if it has to be over the abdomen and the thorax in the anterior side, then the patient is preferred to be kept in a head and raised position, and the chest has to be kept expanded, and the patient has to keep the whole abdomen level contracted. The muscle has to be kept contracted. Vispurjita is contracting the muscles. Then Bahubhyam Avalambamana Dehasya Parshvayoho. If it has to be over the sides, lumbar area etc., the patient has to be kept in a oblique position, held by an assistant with the hands. Then Ananta Medrasa Medre, if at all it is in the genital area, penital area, the penile area, the penis has to be kept straight or kept above, and just below the penis, the location of the rectum function is suggested. Unnamita Vidasya Jihvadasya Adhodihvayam. If at all it is over the tongue in the oral cavity, it has to be, the tongue has to be raised, and the lower surface of the tongue is the preferable area where the bloodletting has to be done. Of course, there is no question of tourniquet put in that condition. Ajivyakta ananasya taluni dantamuleshja. When the it has to be bloodletting has to be done in the talu palate or in the base of the teeth, it has to be in a kept mouth kept open. एवं यंत्र उपायान् अन्यांश्च शिरोत्थान हेतून् बुद्ध्या अपेक्ष शरीरवशेन व्याधिवशेन च विद्यात्. Similarly, you have to make the veins prominent, the vessels prominent, and then do the bloodletting. Of course, bloodletting in the oral cavity, in the genital area, in the back, etc. We cannot comment because I don't have any direct experience of dealing with this kind of a situation where bloodletting is done. So it's only about the theory part. मांसदेषु अवकाशेषु यवमात्रं शस्त्रं निदध्यात् अथवा अन्यथा अर्धयवमात्रं व्रीहिमात्रं वा व्रीहिमुखेन अस्नामुपरि कुठारिकया विद्येत् अर्धयवमात्रं. Now either it's a vinepuncture or vinesection. Whenever there is a vrihimukha shastra, it is a vinepuncture. The vessels have to be punctured and the bloodletting has to be done. And the depth of the puncturing is, in case of a flat, the area where the subcutaneous tissue is thick, mamsala is where the subcutaneous level is thick, like the abdomen or buttocks, etc. It should be as big as a yava. That's something around 0.75 centimeters. Then ardhayava matram, vrihi matram, vrihimukhyena. Elsewhere, depending upon the depth of the or thickness of the tissue, the level could be ardhayava or so on. If it is the vessels are over a bony area, there is a chance of slipping. The vessels may get slip off, and hence in such condition, kutarika is used. The use of kutarika we have discussed in Sutrasthanam, and we have discussed about the Shastras. Kutarika is not hitting; instead, it's producing a rotating movement, circular movement, so that the vessel would be cut as such. So it's a vinesection. So majority of the situation is a vyadhana, vinepuncture. But occasionally it could be vinesection, basically cutting the vessels. Then Vebhre Varshasu Vidhyetu Grishma Kale Shitale Hemanta Kale Madhyane Shastrakaraha Trayasmritaha. If it is Varsha Rutu, then it has to be done in the afternoon hours, in the later half of the day. Grishma Kale, if it is sunny season, warm weather, it should be, in the Varsha Rutu, it should be in the early morning, and Grishma Kale, in the very hot season, in the evening when it is cold. In the Hemanta, in the cold season, it should be in the Madhyana. So the 3 times or the seasonally varying times for the Rakta motion would be: in rainy season, it should be Vebhre in the early morning, and when there is no cloud in a bright day. Vebhre is a cloudless day. And Grishma Kala is Shitala. In the Grishma Kala hot season, it should be in the evening hours and it is relatively cold. And Hemanta Kala, in the cold season, it should be in the Madhyana. Initially, I think I have some misinterpretation initially. Okay. Then Samyak Shastra Nipatena Dharayava Siravyadha Sada Muhurtam Rudhva Tishteta Suvidhanatam Vinirvisheta. A sign of proper puncturing would be the blood has to flow directly as a direct stream-like flow, and for about Muhurta Kala, that's for about some 3 minutes or 2.5 minutes or so, and then it has to stop by itself. Now, a spontaneous closure of a venipuncture wound would be possible only when it is in the minor veins, the smaller veins of the periphery. If at all you have punctured the bigger veins, then there could be bleeding for a longer duration. So that fact has to be kept in mind. And the proper sign of proper puncturing is the bleeding has to stop by itself after a steady stream of the flow. Yatha kusumba pushpebhya purvam sravatvitika tatha sirasu vidhasu dustam agre pravartate. Now, as if a flower which has fully open, like if you hold the flower and then move it, the seminous particles of that flower would be spilled over in the initial stage because they are loosely held. Similarly, Sushruta says the dushta rakta, the vitiated component of the rakta, can be made to flow easily, or it will flow out easily during the Rakta motion. Now, this fact is a controversial issue. From the current physiology point of view, you do not have any such evidences where we can say that the blood which has flown out in the beginning would be having more of these vitiated contents, and later there would be lesser contents. That kind of a logic is not substantiated by the present day's knowledge. So when I say this, I am not saying right or wrong, that's not the issue. But with the present day's knowledge, it cannot be substantiated. Then मूर्छितस्य अतिभीतस्य श्रान्तस्य तृषितस्य च न वहन्ति siravyadhaः तथा अनुत्थितयन्त्रिताः. A failure of bloodletting can occur if the patient is already in a shock condition, or if the patient is unconscious, or if the patient is thirsty. These are all signs of different degrees of the shock. Or if the veins are not properly raised or made prominent, in that condition there could be no bleeding as such. A failure of the bleeding can occur. क्षीणस्य बहुदोषस्य मूर्छया अभिहतस्य च भूयो अपराह्णे विश्राव्याः so aparedhyuh trayepi va. Now suppose if the patient is very weak and the patient has a very prominent disease, or if the patient is unconscious, in such conditions a single sitting bloodletting may not be successful. In such conditions you may repeat the procedure in the aparahna, in the afternoon hours, or maybe after 2 or 3 days after the initial failed attempt. रक्तं सशेषदोषं तु कुर्यात् अपि विचक्षणः न च अतिनिःसृतं कुर्यात् शेषं संशमने हि देयेत्. बलिनः बहुदोषस्य व्यस्तशरीरिणः परं प्रमाणमिच्छन्ति प्रस्थं शोणितमोक्षणे. The maximum amount of your blood which can be removed during the bloodletting is 1 prastha. Now 1 prastha is about 300 ml or 400 ml. So that's the maximum amount which can be removed. Very important. Sushruta has given that limit, the maximum limit of the bloodletting in an adult and who is otherwise physically strong. And in all other patients, according to the status of the patient, the quantity has to be lesser than 400 ml. And you are not supposed to remove the vitiated blood completely, unlike other doshas, other shodhanas. In the other shodhana procedure like Vamana or the Virechana, the target is that all the vitiated dosha has to be removed. So you have that procedure assessing the effect of the shodhana by either vega, number of vegas, or the antas, what is seen at the end. So like kapanta or maybe the pittanta, so on. So in case of the woman and the virechana, you have those procedures, or vaigiki lakshanas. Now in case of rakta dosha, you are not supposed to go to that level where all the doshas are removed. So it's only that the severity of the disease is controlled, and hence only the initial amount of the doshas are removed, and later on the patient needs a samshamana chikitsa or a medical treatment to cure the disease. So rakta mokshana is only a temporary measure of reducing the doshas, and it should be done in the apakvavastha, not in the pakvavastha. These are the two important guidelines which are often missed in the practice. Now, tatra padadaha, the diseases where is indicated are padadaha, padaharsha, tippa, visarpa, vatashonita, vatakantaka, vicharchita, padadari prabhastishu, kshipramarmanaha, uparishthata, vyangure, virihimukshena siravyadha. These are the locations where of the siravyadha in the different disease conditions. Of course, practically how much it has to be done, how much it is practicable, I don't have a direct experience. So it's only the theory part. In the Shripada, Shripade Tachikitse Yathavakshade, in the Shripada, it's mentioned like in Vataja Shripada, it has Vyangustho Parisiramvidyeta, Vataja Shripade Bishaka, whereas in the Kapaja Shripada, it has to be Adhastata Mustasya, below the Angusta. That's how the location is made up, varied according to the doshas. So again, a logical interpretation from the current point of view is not possible. Then Shripade Tachikitsade, then Kloskashiraha Khanja Pangu Vata Baidanasu, Jankhayam Ji Gulfa Sivpari, Chaturangule, in case of Kloskashira and Khanja Pangu, etc. Gulfa Sivpari, Gulfa, above the Gulfa it has to be done, Rakta Mokshana has to be done. And then Apacha Mindrabasteha the Sarvyangule, in the Apachi, which is actually a disease in the neck area, it has to be over the Indrabasti. It's again very interesting issue. In Galaganda, Sushil has mentioned about making an incision in the Indrabasti, that's in the calf muscle area. Again, justification that is quite difficult. And in the Apache, Sushil, in the Apache Chikitsa, it's mentioned like it has to be over the Manibandha, over the wrist area. Patient has a lesion in the neck and the Rakta motion is to be done in the Kuryat Rekhatrayam Vishaka, Manibandhasya Kuryat Rekhatrayam Vishaka. 3 linear incisions have to be made as a treatment. Again, for that, the justification from the current logic point of view is not possible. Janasandehi upari athova chaturangale gridhasyam. In the gridhasi, it has to be above the knee joint or adha, below the knee joint. Janasandehi upari athova, either above or below the knee joint. 4 angulas is the location. Then Urmula Samshita Galagande. In the Galaganda condition, it has to be in the Urmula, just below the thigh is the location. Yetena Itarasakti Bahu Vyakhyatau. Visheshatastu Vamabaho Purpara Sandeha Abhyantarato Bahu Madhye Prihni Kanishika Anamikayo Madhyeva. For Priha, the splenic disorder on the left side, below the elbow joint or in between the small finger, the little finger and the fourth finger, in between that space, in the web space, the location is suggested. Evam Dakshina Baho Ekrat Dalye, in case of liver disorders, it has to be on the right side. Yetam Yamacha Kasashwasa Yoho Api Adishanti. In Kasashwasa condition also, the same are suggested. Grudhasyam Yo Vishwatyam. In the Vishwatya and Grudhasi, the locations are the same. Shonim Prati Samantara Jangule Pravahikayam Shulinyam. In the Pravahika and Shulini, in the Shonim Prati, around the buttocks. Parivartika Upadamsha Shukadosha Shukra Vyapastu Medhamadye. In case of the penile disorders like paraphimosis or the septic gonorrhea like conditions, Metramadye, in between the metra. And Vrishanayo Parshva Mutravdhyam, in the Mutravruddhi hydrocele conditions, Vrishanayo Parshva on the sides of the Prishada. Nabhe Adha Chaturangale Sevanya Vamapashva Dakodare. In case of fasciitis conditions, below the umbilicus is the location. Now, Vamapashva Kaksha Stanayo Antaravidhu Parshashule. Of course, in all these, it's only the theory parts, because practically I don't have any experience, I will not comment much on that. Bahushosha Avbahakayoha Peke Vadanti Amsayoho Antare Trikasanti Madhyagatam Tritiyake Adhaskanda Sandigatam Anyatara Parshasam Chatursake Hanusandi Madhyagatam Apasmare Shankha Keshanta Sandigatam Guru Apanga Lateshu Gunmate Dishwa Rogeshu Ado Dishwayam Dantavyadishuta Taluni Talaveshu Karne Humpari Samanta Karnashule Tadrogeshta Ganda Agrahani Nasa Rogeshu Nasa Gre. So these are the locations. And so practically I don't have any experience, and I have not come across any of the persons who have efficiently used these locations for the treatment. So I don't have any practical knowledge. So I'll keep it as such. And it needs to be explored. It has to be confirmed. So it needs to be explored whether these facts are true or not. Anyway, Dushtavedaha Vimshatihi. The errors of the venipuncture could be 20, and they are Durvidha, Atividha, Kunchita, Pichita, Kuttita, Aprasvata, Ativirna, Antevidha, Parishushka, Kunita, Vepita, Anuttita Vidha, Shastrahata, Tijyagvidha, Avidha, Avyadhya, Vidruta, Dhenuka, Punaha, Punarvidha, Sirasnainasti Sandimarma Sucheti. Tatraya, Sukshma, Shastravidha, Avyaktam, Asrutsavati, Nujasho Bhavati, Sadurvidha. When the instrument which you have used is not proper, and hence the blood flow is not proper, resulting in pain and swelling at the area, that's Durvidha. Pramana Atirikta Vidhaya Manta Pravishati Shonitam Shonita Atipravrittiva Sa Atividha. Atividha is when the quantity of the blood flow is much more than what is expected, and resulting in the complications of Shonita Atipravritti, blood loss. Then that's the Atividha. Kunchitayam api. In the Kunchita Vidha also it is the same thing, like where there is excess of blood loss. Kunta Shastra Pramachita Pruthuli Bhavam Apanna Pichita. Pichita is when you use a blunt instrument and hence the vessel has become flattened or injured, crushed. That's the Pichita Vidha. Anasadita Punha Punarantayoscha Bhusha Shastrabhyata Kuttita. Kuttita is when the location of puncturing is not exact, and hence you have punctured at a oblique manner, and a longer area of the vessel has become injured, that's the kuttita. Shita-bhaya murchabhi abhipravritta shonita aprasuta. Aprasuta is due to extreme cold season or patient's unconsciousness or fear, etc. The blood has not flown due to the systemic causes, that's aprasuta. Tikshna Mahamkha Shastravidha Atyudirna. Atyudirna is when there is a sharp, very sharp instrument is used, and hence the puncture is much more than what is expected. Injury to the vessel is more, that's Atyudirna. Alparakta Stravini Antevidha. Antevidha is instead of puncturing the vessel, you have punctured somewhere near the vessel, and hence the amount of the blood flow is lesser than optimum. Kshinat Shonita Anilapurna Parishushka. Parishushka is where the patient doesn't have enough of the blood. There is actually low volume conditions, and in that condition, if at all the puncturing is done, that's a parishushka. Then Chaturbhaga Asagita Kinchit Pravutta Shonita Kunita. Kunita is when the quantity of the blood flow is just 1/4 of what is supposed to be blood, that's a Kunita. Dusthana Bandhana Vepamanaya Shonita Samoha Bhavati, Sa Vepita. Vepita is when the patient is moving here and there during the bloodletting, and due to that movement, the blood doesn't get floated out and it gets clotted. That's the Vepita. Anuchita Vidhaya Mapyevam. Anuchita Vidhaya is when the veins are not made prominent and then you have punctured. That again is the same. There could be a premature clotting. Chinna Ati Pravutta Shonita Kriya Sangakari Shastrahata. Shastrahata is where the vessel has become completely ruptured and the functions are affected in due course of time. Triyak Pranita Shastra Kinchit Shesha Triyak Vidha. Triyak Vidha is where the instrument is not penetrating in a proper direction, in an oblique direction, and hence the vessel is injured abnormally. Bhushakshata Shirasastra Pranidhanena Avidha. Avidha is the instrument is not optimum, and hence you have used it repeatedly, and hence there is a multiple punctures, that's Avidha. Ashastrakritya Avyadhya. Avyadhya, of course, those vessels which are not indicated where you have punctured, that's Avyadhya. Anavasthita Vidha Viduta. The Viduta is when the puncturing is not enough. You are not having the, instead of going to the level which is required, if it is just above the level or less than the optimum, that's Anavasthita Vidha or Viduta. Pradeshasya Bahusha Avakattanat Arohat Vyadha Muhurmuhu Shonisasrava Dhenuka. Dhenuka is after the bleeding, after the procedure, there is a repeated bleeding due to the movement, that's the Dhenuka. Sufastra Vedhanat Bahusho Bhinna Punah Vidha, where you have punctured repeatedly. Snayamasti Sirata Sandhimarmus Vidha Rujam Shopam Vaikadyacha Maranam Apadayati. Then Dhoti Chatra Sirasu Shikshito Nasti Chalahi Ataha Sobhavataha Marchevat Parivantate Tasman Yatnena Tadayat. Siravyadha needs a lot of skill because the vessels are easily movable, and the movement of these vessels is compared to the fish in water, and hence a proper identification and developing a proper skill of puncturing the vessel is needed. Of course, this is absolutely true in the practical situation when you are collecting the blood for these examinations in the laboratory. Initially it will be always like that. To puncture a vein and collect the blood with a single puncture would be always difficult, and only after having a proper skill you will be able to puncture properly. Ajanata grihite tu shastre kaya nipatite bhavanti vyapadaschetaha bhavashchakvi upadravaha. If a unskilled person, a person without skill has used these instruments, there is a possibility of injury and the complications also can be more. Snehadivi kriya yoge hi na tatha lepanirapi yantya shuvate shantim tatha samyak siravyadha. Those diseases which cannot be treated or which might not have responded to the usual procedures like snehana, svedana, etc., and the or lepana, they may get cured or relieved by siravyadha. Siravyadha chikitsardam shalitante prakirtitha tata pranihita samyak basti yatha pranihita samyak basti kaya chikitsite. In the Shalitantra, Siravyadha is considered as Chikitsartha, Ardha Chikitsa, half of the treatment. So, majority of the diseases can be treated by Siravyadha as per Sushruta statement, and it's compared to the Basti in Kaya Chikitsa. Practically, how much of this is true? Again, there is a question mark. तत्र स्निग्धस्त्विन्न वान्त विरिक्त आस्थापित अनुवासित सिराविद्धेः परिहर्तव्यानि क्रोध आयास मैथुन दिवास्वप्न वाक् व्यायाम ज्ञान अध्ययन स्थान आसन संक्रमण शीतवात आतप विरुद्ध असात्म्य अजीर्णानि अबललाभात् मासमेके मन्यन्ते। एतेषां विस्तरम् उपरिष्टात् वक्ष्यामः। Now, in all Shodhana procedures, after the Shodhana, patient has to avoid either psychological stresses or physical stresses have to be avoided. Psychological stresses like anger and then sexual activity, study and so on. Physical stresses like walking, excessive activity or exposure to the sunlight or exposure to the cold, etc. These are to be avoided because the patient would not have sufficient strength, the sustainable strength in the body, and for about a month the protocol has to be followed, protective protocol has to be followed for a month in Tattamokshana. Whereas you have the Parihara Kala which are mentioned in the different Shodhana procedures, that again where you have to take care of the diet, and of course the strain and physical activity also have to be regulated for a specified period in each of the Shodhana. शिरा विषाण तुम्बेस्तु जलोकापि प्रदेशत अवगाढं यथापूर्वं निष्क्रियं दुष्टशोणितम् अवगाढे जलोका स्यात् प्रच्छन्नं पिण्डिते हितं शिरा अंगव्यापके रक्ते शृंगाराभूत त्वचि स्थिते. Now the Rakta Mokshana could be done by either siravyadha or vishana, that's the shringa or these horns of the animals, or you use a suction, or alabhu, again you use a suction, jaloka. The four techniques are the Rakta Mokshana. Now the limit would be, or indications would be avagade jaloka syata. In case of deep seated lesions, it's jaloka which is indicated. Prachana, that's where you have to make a superficial skin incision or subcutaneous bleeding. In case of pindite, localized conditions or indurated condition. Sira Angavyapake, Siravyadha is in a systemic disorder. Siravyadha is indicated in systemic disorder. Shringara, Bhuktachisse, subcutaneous lesions of Shringa and Alabu are indicated. So there is a very specific indication for each of these procedures, and only that kind of a specific indication has to be used in the when you use the techniques practical. Now that's about the what Sushira has mentioned. Now a brief about what the Western system would be having. With the Western system, if you look at the history of the Western system, bloodletting was very popular in the Western system of medicine. And if you follow Celsius, who is considered to be one of the most or oldest and the most important predictor of the preacher of the Western system of medicine, who is also called as the father of the Western system of medicine occasionally. His statement is, to let blood by inciting a bean is not a novelty. What is novel is that there should be scarcely any malady in which the blood should not be let. So almost every disease in Celsius book in 25 BC, every disease has to be treated with the bloodletting as the procedure, and the bloodletting was very popular in the Western system. Ambrose Pare, one of the major, most important person in the Western system, in the Western surgery, in 1634, his book also gives some specific indications for the bloodletting, and that specific indications for the bloodletting are the one is for diversion and reversion. The disease could be either diverted, procedure of the lesion of the disease could be either diverted or it could be reverted by bloodletting. So temporarily the disease could be suppressed. That idea of temporary suppression of the disease or curing the disease could be disease with bloodletting was suggested by Pare. Or in those conditions where there is an excess, trouble with the plenitude, where there is an excess, there again the bloodletting is indicated. So indications for the bloodletting with this specificity was done by Ambrose Pare in 1634. Before that 17th century, the bloodletting was done as a protocol for every disease. That's the important. Now we have to compare what Sushra has said and what the Western system has said. Sushra had specified the indications for the bloodletting much earlier on that. All these protocols are specified and the indications are specified, the locations are specified. You have a full knowledge of the whole protocol limitations in Sushrutamrita. Whereas in the corresponding period in the Western system, it was somewhat irrational. And the rationality, a bit of rationality was added by Ambrose Paré in 1634, where it's considered like the diseases like quinsy, pleurisy, falling sickness, apoplexy, madness, gout, or in such as are wounded, to prevent the inflammation which is to be feared. The inflammation can be prevented. This is the specificity of the indications mentioned by that. In the Western system, it was very popular, and the whole major issues were in early American history also. Benjamin Rush was one of the most important physician in that time, who had a theory like there is a vascular tension in all the diseases, and hence all the diseases, including mental diseases, would respond to the bleeding and subsequent purging. The Virechana has to be was suggested, and this bloodletting was a global practice as such. And the idea of bloodletting by Rush is who was considered to be one of the most prominent surgeons in American history. You may have to repeat the bloodletting in 2 to 3 times or within 48 to 72 hours so till the patient has shown the result. So in the Western system, the whole area of this bloodletting was very popular, and the locations, points of bloodletting also were are available as in the historical facts, like the Field Book of Wound Medicine in 1517 by Jesdorf. You have that diagram of locations where the bloodletting can be done. So specific points also were there. So on that point is the all that point is bloodletting was very popular in the Western system in those days, and the whole almost throughout globe, everywhere the bloodletting was used, and you have these different sorts of the instruments used for bloodletting in different areas, and these are available in China, France, and so on. So you get that information throughout the globe. But the whole downfall of the technique, it has the whole surgery, this bloodletting has got the downfall and had become obsolete after one of the major incidents in the history of medicine. That major incident in the history of medicine was George Washington, the first president of America. He suffered with epiglottitis, and he was treated with the bloodletting for and roughly about 3.7 liters of blood was removed, and he died in on 14th of December. Cause of death, of course, there was always a confusion, and it was confirmed in 1905 by Edinburgh Conference that it was due to the bloodletting that he died, not due to the epiglottitis. So after this, the bloodletting has become obsolete, and now that bloodletting technique is categorized as a torture procedure of medieval culture. And in the present day situation, bloodletting is limited to only a few of the conditions. As far as the advantages of the regular blood donation, they are now known, and it's now known that regular blood donation, which is a practice which can supposed to promote the health, and there are established reports of this, like either it reduces the risk of coronary disorder, regulates lipid profile, reduces iron storage, it reduces the risk of cancer, stimulates liver enzymes. These are the advantages, and plenty of articles about this also are presented. So those who are interested in reading the advantages of regular blood donation, there are plenty of articles where the studies are done in large number. Then even now there are certain disease conditions where the bloodletting is a treatment, and they are very limited, like hemochromatosis, polycythemia, porphyria, or in future they maybe latest are in hepatitis and diabetes mellitus also. Bloodletting is supposed to be one of the maybe possible treatment in future. So that's about the comparison of the bloodletting in the current system and Western system history. And from practical point of view, all that is there are many centers in Ayurvedic centers who do that bloodletting procedure, but most of the procedures are not as per the text, and I have not come across any of those centers where the exact locations of the bloodletting mentioned by Sushruta are practiced And as far as the clinical outcome of bloodletting is concerned, from my point of view, I have not seen any patient recovering fully. Only there could be a temporary relief. And from my practical clinical point of view, I have done this procedure in very low numbers, and my experience is not very supportive. With this, let me conclude. If there are any questions, we will try to answer the questions. There is one question. Can you share any clinical? Yeah, I think you have. I have already told that I don't have much advantageous clinical procedure experience with the bloodletting. So my experience there is very limited. So most of the issue is a theory. Okay, right. No more questions, right?